Today we are going to be discussing pressure injuries and documentation requirements. In April 2016, the NEUAP updated the staging system and definitions for pressure ulcers. New terminology: pressure ulcers is now referred to as a pressure injury, Roman to Arabic numerals, updated and improved artwork, revised definitions for each stage. They also added definitions for medical device related and mucosal membrane injuries. An ulcer is defined as a break in skin or mucous membrane with loss of surface tissue, disintegration, and necrosis of epithelial tissue and often pus. An injury is described as a bodily damage. Ulcer does not accurately describe the physical presentation of a stage 1 or a deep tissue injury. You can have an injury without an ulcer, but you cannot have an ulcer without an injury. A pressure injury is localized damage to the skin and underlying soft tissue, usually over a bony prominence or related to a medical or other device. The injury can present as intact skin or an open ulcer and may be painful. The injury occurs as a result of intense and/or prolonged pressure or pressure in combination with shear. The tolerance of soft tissues for pressure and shear may also be affected by microclimate, nutrition, perfusion, comorbidities, and condition of the soft tissue. This slide demonstrates progression of a pressure injury from a stage 1 to a stage 4. Other risk factors for pressure injuries include excessive moisture. Although moisture on the skin does not directly cause pressure injuries, it softens or macerates the skin, making it more susceptible to damage from friction and shearing. Dryness, on the other hand, when the skin has lost its moisture, it becomes dry, flaky, and less flexible. Pressure injuries are more likely to develop from dry skin. In the next slides, I'm going to be covering mechanical factors. Two types are friction and shear. The first one, friction, is the resistance encountered when one body surface is moved in contact with another, causes superficial skin loss, such as abrasions or rug burns. Shear. Friction in combination with gravity leads to shearing. Shear is made up of shear stress, which is the amount of force per unit, and shear strain, the amount of distortion of underlying tissue from stress. Superficial shear strain can cause skin tears, but deep shear strains can lead to pressure injury development. I'm going to break things down into top-down injuries, which are not pressure-related, and bottom-up injuries, which are pressure-related. Friction was removed from the new definitions for pressure injuries. Moisture and or friction are now included in the top-down injuries. Those include MASD, which actually include 4 areas, but I'm only going to cover 2, incontinence-associated dermatitis and intertriginous dermatitis, and MARSI, which is medical adhesive-related skin injuries. Mechanical factors that contribute to pressure injuries include, of course, pressure, the amount of force perpendicular to the skin resulting in tissue and vessel compression. 4 factors are involved in pressure injury development. You have the vessels that compress and result in ischemia and necrosis, occlusion of the lymph vessels, which result in impaired removal of waste products and therefore causes increased edema. You have a reperfusion injury due to the accumulation of O2 free radicals and a direct damage to the cytoskeleton of the muscle cell at the muscle-bone interface. In this slide, you can see an example of MASD, incontinence-associated dermatitis. In the slide, you can see that the person has superficial skin loss, but it's not related to pressure, it's related to incontinence. Intertriginous dermatitis is caused from certain risk factors, including obesity, poor hygiene, trapped moisture or prolonged exposure under deep skin folds, and typically with patients that have diabetes. Bottom-up injuries involves pressure intensity and duration. Again, it's caused from pressure and shear damage. Bottom-up damage is caused by the intense or sustained compression of the tissue and begins at the muscle-bone interface. In the next slides, we are going to be going over the definitions of the stages of pressure injuries. A stage 1 pressure injury, non-blanchable erythema of intact skin. It presents as intact skin with a localized area of non-blanching erythema, which may appear differently in darkly pigmented skin. Presence of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Color changes do not include purple or maroon discoloration, as these would be described in a deep tissue injury. The key factor in this is looking for whether the skin blanches or not, and it is very important to put that in your progress note, because if it blanches, it's not a stage 1 pressure injury, but if it doesn't blanch, then you would need to go further into your assessment. The next two slides show a stage 1 pressure injury in lightly pigmented skin and darkly pigmented skin. It may be more difficult to determine in a person that has dark pigmented skin. Often then you need to look for signs of changes in sensation, temperature, or firmness. Example would be mushy, boggy heels. In this slide is an example of a stage 1 pressure injury to the heel. As you can see, there's no blister, so it's not a stage 2 and it's not a deep tissue. You have pink, non-blanchable erythema, so it would be a stage 1. Stage 2 pressure injuries. They are partial thickness loss of skin with exposed dermis. The wound bed is viable pink or red, moist, and may present as an intact or ruptured serum-filled blister. Adipose tissue is not present, and deeper tissues are not visual. Granulation tissue, slough, or eschar are not present. These injuries often result from adverse microclimate and shear in the skin over the pelvis area and on the heel. This stage should not include anything that is related to top-down injuries such as MASD, IAD, ITD, MARSI, or any skin tears, burns, or abrasions. This slide demonstrates the progression of a stage 2 pressure injury. It goes through the epidermis into the dermis layer, but not into the other layers, so you don't have any visible adipose tissue or any other visible tissue. This slide shows a stage 2 pressure injury to the coccyx area. Most likely this person had pre-existing incontinence-associated dermatitis, but then developed a superficial opening to the sacral area. This would be classified as a stage 2 pressure injury. This slide shows shearing to the buttocks. As you can see, both sides almost appear equally, and the skin was most likely very moist, and the resident had incontinence. And related to shearing, it took off that superficial layer of skin, and due to that it was shearing force, this would also be considered a stage 2 pressure injury. This is an example of an intact serum-filled blister, so that would be considered a stage 2 pressure injury. This slide also shows a stage 2 pressure injury. It looked like there was an intact serum-filled blister, and the blister became really moist and opened up into the dermis layer, so this would also be considered a stage 2 pressure injury. Stage 3 pressure injuries include full thickness loss of skin, in which adipose fat tissue is visible in the ulcer and granulation tissue and epibole, which is a rolled wound edge, are often present. Slough and/or eschar may be visible. The depth of the tissue varies depending on where it is on the body. Areas of significant adiposity can develop deep wounds. Undermining and tunneling may occur. Fascia, muscle, tendon, ligament, cartilage, and/or bone are not exposed. If the slough or eschar obscures the extent of the tissue loss, this is considered an unstageable pressure injury. This slide shows the progression of a stage 3 pressure injury. We've gone through the epidermis, dermis, and into the adipose tissue layer. This slide gives an example of a stage 3 pressure injury with epibole. As you can see, the wound has a rolled wound edge. This is epibole. This slide shows an example of a stage 3 pressure injury. As you can see that there is slough in this wound, so therefore it would be classified as a stage 3 pressure injury. This wound also shows slough about at the 11 o'clock, and also you can see the circle of the epibole, the rolled wound edge, and this wound has that white macerated ring around it. That would mean also in this wound that this wound is too moist. So that's what you're seeing there, and that white shiny skin is maceration. As I said earlier, you might have tunneling or undermining, and we'll be going over those more in depth when we go into the documentation process. But this is an example of a stage 3 pressure injury with tunneling. Stage 4 pressure injury is full thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough or eschar may be present. Epibole, undermining, and or tunneling often occur, and depth varies by anatomical location. And again, remember, if eschar or slough obscures the extent of tissue loss, this is an unstageable pressure injury. Progression of a stage 4 pressure injury. So we've gone through the epidermis, dermis, subcutaneous layer, and now we're into the muscle, bone, ligament, tendons, as you can see in this picture. This slide demonstrates a stage 4 pressure injury in a couple areas here, and most likely there's a lot of underlining and undermining going on in this wound. In fact, the two issues probably track together. This is a pretty significant stage 4 pressure injury. In this wound you can see slough present, and you can also see probably some bone and ligament. So this would be considered a stage 4 pressure injury. Unstageable pressure injury is full thickness skin and tissue loss in which the extent of the tissue damage within the ulcer cannot be confirmed because it is obscured with slough or eschar. If slough or eschar is removed, it will most likely be a stage 3 or stage 4 pressure injury. Stable eschar, such as dry, adherent, intact without erythema or fluctuance on the heel or ischemic limb, should not be softened or removed. This is contraindicated. In this slide you can see the progression of the pressure injury, and because it is hidden by slough and eschar, it is unstageable. In this slide you can see a pressure injury on an ankle which is obscured by the slough and eschar, so it would be an unstageable pressure injury. This wound has eschar on there, and again would be considered an unstageable pressure injury. Deep tissue pressure injuries usually present as intact or non-intact skin with localized area of persistent non-blanchable deep red, maroon, purple discoloration, or epidermal separation revealing a dark wound bed or blood-filled blister. Pain and temperature changes often precede skin color changes. Discoloration may appear differently in darkly pigmented skin. This injury results from intense or prolonged pressure and shear forces at the bone-muscle interface. The wound may evolve rapidly to reveal the actual extent of the tissue injury, or may resolve without tissue loss. If necrotic tissue, subcutaneous tissue, granulation tissue, fascia, muscle, or other underlying tissues are visible, this indicates a full thickness pressure injury. Do not use deep tissue pressure injury to describe vascular, traumatic, neuropathic, or dermatological conditions. This slide demonstrates a deep tissue pressure injury. In this slide, you can see an example of a deep tissue pressure injury. As you can see, the skin is dark purple, almost maroon in color. The skin is intact, but this is a very significant deep tissue injury. In this slide, you can see an example of a heel. Different from the previous slide that I showed you earlier. As you can see, this blister is intact, but it has a different color. It's going to be maroon or dark purple. Oftentimes, when people have a serum-filled blister with a deep tissue injury, when the blood absorbs back into the body, what we'll see is a eschar cap. It is usually contraindicated in sharp debriding. The best thing to do is leave it be, and it'll heal from the inside out. In this slide, you may first think that this is an unstageable pressure injury due to eschar. However, this isn't over any place on the body that would result in a pressure injury. This is an example of calciphylaxis, which results when calcium and phosphorus deposit in the vessels of usually patients that are on hemodialysis and causes ischemia, which then causes the tissue to die and causes eschar on the skin. In this case, debridement is contraindicated. Staging of pressure injuries. Couple key points is you never reverse a pressure injury. If it's a stage 3, it's always a stage 3. It's a stage 3 resolving or a stage 3 healing. Skin failure results from hypoperfusion that creates an extreme inflammatory reaction of the body. It causes severe dysfunction and failure of multiple organs. Skin can and often does fail. It is not pressure injury unless pressure and/or shear is involved. Communicate and educate families and residents about the end-of-life process and pressure injury occurrence. Kennedy terminal ulcer. What is it? It's a sudden onset of a pressure injury on the sacrum. It usually appears as a pear, butterfly, or horseshoe shape. It's red, yellow, black, or purple in color. It has irregular borders, and it starts as a stage 2 blister with rapid progression. It usually means death is imminent. This slide shows an example of a Kennedy terminal ulcer. Medical device-related pressure injuries result from the use of devices designed and applied for diagnostic or therapeutic purposes. The resultant pressure injury generally conforms to the pattern or shape of the device. The injury should be staged using the staging system that we went over. Make sure you monitor pressure from medical devices. O2 tubing, CPAPs, BiPAPs, Foley catheters, etc. Increased risk with impaired sensation, moisture under device, poor perfusion, altered tissue tolerance, and poor nutrition status and edema can contribute to pressure injuries from medical devices. Make sure you relieve pressure and inspect frequently. Look up, down, and all around. It is also important with anyone with a brace, AFO, splint, etc. that you have CMS in check, and also make sure you remove that device and look everywhere. We have had some deep tissue pressure injuries result from not looking at the skin entirely under the device. Make sure it is on your ETAR so that each shift can check the skin status. Mucosal membrane pressure injuries are found on the mucous membranes with a history of medical device in the use of the location of the injury. Due to the anatomy of the tissue, these ulcers cannot be staged. In the next few slides, I'm going to be going over some other wounds that are not pressure related. First, we're going to cover arterial ulcers. This is an example of an arterial wound. For arterial ulcers, usually you'll find them on the tip of the toes, pressure point areas, or areas of trauma. They are shallow to deep. The wound bed is pale and necrotic. The wound edge is usually defined, has a punched out appearance. The peri-wound might have a faint halo of erythema. They might have some slight induration, usually minimal drainage. An infection is common, however, they might have muted symptoms. Some tidbits for PAD. Residents with PAD should typically not wear compression stockings. Compression stockings further impede blood flow in people with PAD. Make sure you talk to their clinician if your resident has been prescribed compression of any kind, whether that is ACE wraps, TED hose, JOPE stockings, or 4-layer compression wraps. A resident with PAD should not wear compression without having baseline studies done to show what kind of circulation they have. Doppler study is usually the recommended for anyone with a PAD diagnosis. Next, we are going to be covering venous stasis ulcers. This is an example of a venous stasis ulcer. Venous stasis ulcers are usually over the medial malleolus or anywhere between the ankle and knee region, which is called the gator region. Wound base is usually shallow, ruddy red, yellowish or fibrinous slough is present. Granulation tissue may also be present. The wound edges are very irregular and poorly defined. You're often going to see maceration, crusts or scales, and lots of edema. They're going to have moderate to high drainage. Systemic infection is uncommon, however, dermatitis and or cellulitis is very common. A little tidbit for PVD. Residents with PVD should have ABIs done before compression is started. If they have a component of PAD, it must be ruled out, as compression can be contraindicated, like I covered earlier. For ABIs of 0.6 to 0.8, mild compression is okay. If below 0.6, it is not recommended. Usually 4-layer compression wraps are ordered until the resident can be placed in a compression stocking. Consult your occupational therapist as indicated. Next, we're going to be going over diabetic, which are also called neuropathic ulcers. Diabetic ulcers are usually on the plantar surface over metatarsal heads. They are present on areas of the foot where repetitive trauma can occur. Wound bed is shallow to deep, typically red, if not ischemic. The wound edge is punched out or well defined and has a calloused rim. The peri-wound, again, usually a callus is present. You're going to see small to moderate exudate. Infection is common, however, they will have vague symptoms. If you can probe to the bone, expect osteomyelitis. The only way to determine that is to have an MRI. In your assessment, you're going to first determine what kind of wound you have. If it's a wound, you're going to classify it, and if it's a pressure injury, you're going to stage it. What are the characteristics of that wound? What is the progress towards healing? Is there any signs of infection present? Make sure you assess, treat, and monitor for pain. Monitor the dressing and treatment. Is it effective? If there is no progress towards healing made in 2 to 3 weeks, the resident's clinical condition needs to be reassessed, modify interventions, reevaluate plan of care. If continued treatment plan is recommended, we must document in our progress notes or in a physician progress note the rationale in their medical record. In your documentation, you should include location. Is it a pressure injury or wound? If it's a pressure injury, what stage is it? If it's a wound, make sure you classify it. What size is it? What color is it? What drainage? Including the type, amount, and any odor present. What does the peri-wound skin condition look like? And what is the size of the peri-wound involvement? Disciplines of wear, treatment, and if they're having pain, yes or no. It is our standard for documentation that daily monitoring is occurring if no dressing is present. Evaluate for drainage, surrounding skin, odor, signs of infection, and any pain the resident may be experiencing. If the dressing is in place, make sure that it is being monitored every shift or at least daily to make sure the dressing is intact. And our minimum requirement for charting on skin assessments is weekly. I will be now covering in the next slides how to use the PCC Skin and Wound app. you must first access the app on the neighborhood phone. Enter your organization code and username. You must enter VALM and then click on Start. The partner login, this is your username that you use to log into PCC. The password is also the same as your PCC password. The first screen to pop up will be the camera screen. Make sure you are in the correct facility and make sure you search for the correct resident. Once you find the resident you are assessing for their skin, click on that resident. For a new wound, you would then take the picture and do your assessment and measurements. For an existing wound, you must click on that wound listed and then in the top right corner, click on the plus sign and then take the picture and do your assessment and measurements. As you can see in this slide, this resident has 2 pressure injuries, 1 to each heel. So it's very important that you click on the correct one so you take pictures of the correct ulcer for measurements and progress towards healing. Make sure when you are taking the picture that you have the blue sticker in place. I like to place the sticker pointing towards the direction of the head so that when you take the pictures from week to week that you will have the same outlook for the picture and hopefully better measurements to look at week to week for healing progress. You will know that you have a correct distance when the blue sticker glows orange. That is when you want to take the picture. Some pointers for the PCC Skin and Wound app. You must do the area by tracing. This determines the length and the width. If there's any depth, undermining, and tunneling, you must enter that in centimeters. Measurements must be done on the phone app. You must also classify the wound by type or stage if it's pressure. You have to put its location on the phone app. Use the body to rotate to find your location of the wound. You must also put facility acquired, whether it's in-house or external, and the wound age if you know. All other items may be entered on the computer under the UDA Assessment in Progress tab, Sort by Type, or under the Individual Resident Assessment tab. Make sure you are again documenting on the correct wound if they have multiple wounds. In the next few slides I'm going to be going over some verbiage that's used in the PCC Skin and Wound documentation. Types that you're going to be able to choose from are abrasions, bruises, arterial, blisters, cancer lesions, diabetic, hydradenitis suppurativa, which I'll cover later, lacerations, MASD, mole, open lesion. Be careful with bruises. Our policy does not state that we have to take pictures of all bruises. Unless it's something substantial that you're monitoring, such as a hematoma, I would really not take pictures of bruises. Just add it to your TAR to check weekly on that day until it's resolved. If it's a new bruise, you'd want to fill out an injury report form and again put it on the TAR to check weekly on bath date until resolved. Same with abrasions. It has to be greater than 2 by 2, so just be careful with that. Don't cause extra work on your part. If it's greater than 2 by 2, then you would have to take pictures weekly until resolved. Again, continued pressure injuries, rashes, again, caution, unless it's something you're monitoring and chart on weekly until resolved. Otherwise, we really don't need to take pictures of rashes. Skin tears, again, if it's greater than 2 by 2. Surgical wounds are usually closed by sutures and staples, so again, unless you're monitoring for other reasons such as infection, dehiscence, you don't need to take a picture of a surgical wound. Venous stasis ulcers would be another choice. Hydradenitis suppurativa. Not quite sure how to pronounce that word, but that's my closest guess. Chronic skin condition featuring lumps in places such as armpits or growing. Basically, they look a lot like inflamed hair follicles. These people end up usually needing to have these lanced and need oral antibiotics. For location, make sure you enter the location on the body, click on and rotate to get the best, closest, correct location for your wound or pressure injury. For wound age, enter wound age from initial acquired date if in-house. For external, if you know exact acquired date, enter that. If not, then click on known. If you know the exact date, you can enter it under 19A. Again, the wound measurements must be done on the phone app. Make sure you put the helix sticker close to the wound and in the same location each time you take the photo. Pointer, make sure you place in the location pointing towards the resident's head. It will make it easier to point arrow up when you know the correct direction. When you trace the wound, it will calculate the length and the width and the surface area. You must enter manually any depth, undermining, and tunneling on the phone app. Undermining is deep tissue damage around the wound margin itself. Tunneling is just under the skin surface and doesn't involve deep tissue. Sinus tracts are a narrow tract that are away from the wound margin and go downward into the wound. Tunneling wounds have channels that extend from a wound into and through the subcutaneous tissue or muscle. They are often difficult to manage and may persist for a long period of time. They can occur from a variety of reasons and are usually associated with infection and result in the destruction of tissue. This is the definition of epithelium. Basically, it's avascular tissue composed of cells that cover the exterior body surfaces and also line internal closed cavities such as the vascular system and body tubes that communicate with the exterior, the alimentary, respiratory, and GI tracts, for example. Wound bed definitions. Eschar, slough, and granulation tissue are in these slides below. Eschar is the covering that looks thick, dry, black, and it's made from necrotic tissue. Eschar may be allowed to slough off naturally, or it may be surgically debrided if indicated. Slough is a mass or layer of dead tissue separated from the surrounding or underlying tissue. It's usually creamy, yellow, or light tan in color. Granulation tissue is the new connective tissue, and it contains tiny blood vessels that form on the surface of the wound during the healing process. When you are assessing a wound, you want to assess for any evidence of infection. If the resident has any fever, any streaking, increased drainage, warmth, malaise, weeping of the wound, or increased pain. If any of these are present, you must notify the nurse practitioner or MD. You're also going to look for any signs of bleeding, if the wound is sutured. If it's overgranulated, you're going to see big red buds in the granulation tissue. You're going to look for gangrene, hematoma, scab. Again, this is different than an eschar or slough covering. Islands of epithelium, fibrin, or bone. In this slide is an example of islands of epithelium. You can see the granulation tissue in the wound bed. Those are those little red bumpy areas. And in between all that looks like little islands of new tissue growing in between the granulation buds. So this would be an example of islands of epithelium, which is not good in this case because they're not connected and filling in fully across the wound surface. This is an example of fibrin. Fibrin is an insoluble protein formed from fibrinogen during the clotting of the blood. It forms a fibrous mesh layer that impedes the flow of blood. This would need to be surgically debrided for the wound to heal. For exudate, you need to determine the amount of exudate present on the dressing when you change the dressing. Is it light? Is it moderate? Is it heavy? Is it none? Make sure you check the box for the amount of exudate present. In the next slide, it goes over the different types of wound drainage. Be familiar with these for your documentation. You have sanguinous, serosanguinous, serous, and purulent. Sanguinous contains blood, so you're going to see dark or bright red. Serous is clear or watery. And if you have serosanguinous, you're going to have a mixture of the two. And purulent is going to be viscous, and it varies. It's going to probably be yellow, white, or green in color. It is very important when assessing for odor that you do it after the wound is cleansed. It is recommended to cleanse with a wound cleanser. Mark absent, faint, moderate, or strong. Periwound is referring to the area around the wound itself. You're looking to see if the wound edge is attached, is it not attached, is there rolled edge, epibole, or is there epithelialization. In regards to the periwound surrounding tissue, is it intact? Is it macerated? You're going to see a wet, white, shiny appearance to the skin around the wound edge. Is it excoriated? Is it discolored? Is it black and blue? Is it fragile? Is it dry or flaky? Is there a blister present? Is it dark reddish brown? Any blanching, scarring, erythema? You might be bright red to dark red to purple erythema. And then if you do have any of these, what is the extent in centimeters? Induration and edema. This induration is hardening of the skin tissue surrounding the wound. It usually means that the wound is infected or you have dehiscence. If induration is present, measure in centimeters and record. This is not referring to just the edema or swelling in the lower extremities. This is related to the periwound. Measure the edema or swelling and document accordingly. Skin temperature, we don't really have the ability to measure temperature of the skin, so leave this 0.0. And then for temperature, by touching the extremity or the wound location, is it cool, is it normal, or is it hot? This is monitoring and assessing for signs of infection. Make sure you always assess for pain. For the cognitively impaired person, you will need to go through a comprehensive pain assessment part. But if they're able to rate the pain, use the pain scale, 0 through 10. Goals of care. This is often one item that is often forgotten on documentation, and it will often sit incomplete and in progress. You must mark what the goal of care is. Is it healable, slow to heal, or are we monitoring or managing? For example, skin failure, end of life, palliative care. Next, we're going to go into treatment. Is the dressing intact, missing, dry, saturated, or leaking? How are you cleansing the wound? Are you using normal saline, sterile water, soap and water, just water, Dakin solution? I hope no one's using hydrogen peroxide. Cetiramide, which we don't usually use here, it's usually used in hospital setting. Chlorhexidine, same thing, that's usually used prior to surgical procedures. Acetic acid, which is over the counter, not over the counter, you get it from a pharmacy, it's made with vinegar, used to treat pseudomonas. Or providine iodine, which is your betadine swabs, other or none. Debridement, the most type of debridement that we do in our facility is moist wound healing. That's the use of ointment such as Metahoney or dressings. That would be considered autolytic debridement. Mechanical, we've done, typically surgeons will prescribe this a lot, doing wet to dry dressings. That would be considered mechanical debridement. Sharp debridement can only be done by a nurse practitioner or MD. Enzymatic would be your collagenase, which can only be obtained through pharmacy and a doctor's order. We have done maggot therapy here in our facility that would be considered biologic. And then surgical outpatient, which we've had some people go over for surgical debridement. If none of these are indicated, then we would mark not indicated. Primary dressings and secondary dressings, make sure that you are coding the correct dressing that you are using. If you are not familiar, make sure you review your handout on formulary of wound dressings that can be found in your nursing how-to guide. The primary dressing is the dressing that covers the wound bed itself, and if you are using two dressings, the second dressing will be your secondary dressing. Example, Aquacel AG and a foam adhesive border dressing. Your Aquacel AG would be your primary, and your secondary would be your foam. When in doubt, make sure you look at the packaging to see what classification it is under. Also, you can also Google it. Pretty two easy ways to figure out what type of dressing you are using. Modalities. Most of the modalities listed in PCC Wound App are something that we don't do here in our facility, but can be done at outpatient wound clinic. The one thing that we do here though, however, they have to be a resident first and it has to be prescribed. We do not take new patients on wound vacs, but that would be considered negative pressure wound therapy. Under additional care, make sure you mark any additional care items that we are doing for that resident. Nutrition and dietary, be careful with this one. This is for wound healing itself, not for weight loss, if they're receiving supplements. Compression, cushions, foam mattresses, all of ours are considered pressure redistribution. We do have the mattresses that can convert to air mattresses, that would be pressure relieving. Heel suspension and protection devices such as the Prevalon boots, Rook boots, heel bows. Mattress with a pump would be our air mattresses. Positioning wedges, we can also include body pillows under this. Turning and repositioning, make sure though, however, that you have a task in the POC task to count this. Otherwise, it does not count because we have to have documentation in place. Other items would be repositioning, foot cradles, moisture barriers such as our Alavis #3, Calmos, Coronas, mobility aids, incontinence management, so any briefs, pads, etc., chucks, and then other or not indicated. Again, this is one that I find often a reason why the UDA is sitting in progress, is that the progress has not been checked. You have to put if it's new, improving, stable, stalled, deteriorating, if it's resolved, or if you suspect infection. And then you can include any notes here that you wish and any education that you provided. Make sure again, if you have seen no progress towards healing within 2 to 3 weeks, that you contact either the nurse practitioner, the MD, or myself to consult on the treatment and see if anything needs to be changed, because we must document why we are either continuing with the same treatment if no progress towards healing is being made, or if we're going to change the treatment at that time. For any new wounds, you must contact the practitioner, the resident or responsible party, dietitian, therapy, and then enter the names of who you contacted. For existing wounds, you do not need to mark this each time unless you notify them something regarding anything such as worsening or suspected infection. Make sure you save, sign, lock, and exit. To be sure, look under the UDA in Progress tab or Assessment tab daily for any skins that are due or ones that are sitting in progress. Check your wound and skin dashboard daily and each shift. Make a progress note. You do not need to repeat everything that you put in the documentation because that's there itself as a standalone document, but any other things that you want to include in your assessment. You can also make reference to the PCC skin and wound assessment for your assessment and documentation purposes. This ends our session on skin documentation and pressure injuries. If you have any questions, please, I recommend to look at your licensed nurse how-to guide. If that doesn't answer your question, You can always reach me at hebertowski@valleyseniorliving.org or at 787-7909. Thank you, and this ends our session.